Hi, everyone, and welcome to our immunotherapy treatment chapter. This is part of the Myeloma Crowd Community Program by HealthTree, and my name is Audrey Burton-Bethke, and I'm the Myeloma Crowd Community Manager. I'm grateful for your support and for your participation here, being here, choosing to be here today. I want you to know that today's session will be recorded, and this will be sent out. The recording will be sent out to all registrants 24 to 48 hours after the event has concluded. I'd like to share some slides briefly with, let me make sure I'm doing this right. um, with just a couple announcements before we turn the time over to our featured speaker. Special thanks to our sponsors without whom this would not be possible: Bristol Myers Squibb, Amgen Oncology, Karyopharm Therapeutics, AbbVie, Adaptive Biotechnologies, Genentech, Oncopeptides, and Takeda Oncology. Today's topic is going to be knowing your myeloma therapy, BLENREP. Jenny Ahlstrom, the founder of the Myeloma Crowd by HealthTree, is going to explain to us why we decided on this topic, and then she will introduce Dr. Richter. So Jenny, I'll turn the time over to you.
Hi, and welcome everybody. This, in my opinion, is a really important chapter in our new community chapters because immunotherapy is sort of taking center stage. And Dr. Richter may, you might agree or disagree with me on that. But we're seeing more immunotherapies in development. We're seeing them come earlier in the clinic and clinical trials anyway. And so it's really important for us to learn how these different treatments are being used. Now, BLENREP has been FDA approved. So it is the first antibody drug conjugate that's being used in multiple myeloma care. And it has a variety of uses. I would like Dr. Richter to discuss today how it should be used, when it should be used, for whom it should be used. And then I'd like this to be more interactive with a lot of questions during the Q&A, because this is an opportunity to hear from a leading myeloma specialist about a specific drug that's being utilized now in the clinic. So with that, Audrey, do you want to share the next screen? So Dr. Richter is assistant professor of medicine in the Tisch Cancer Institute, Division of Hematology and Medical Oncology, director of the Multiple Myeloma Program. And I'm not going to say that properly, though. You're going to be able to say that, Dr. Richter. At Mount Sinai. Dr. Richter has extensive experience with clinical trials focused on new therapies, including antibody therapy and immunotherapy. He's published extensively. He is a leading research that is involved in executing these clinical trials and is a great contributor to the myeloma crowd. So, Dr. Richter, thank you so much for joining us today. And I'm just thrilled you're here.
Thank you so much. Yeah, Blavatnik. People have a
Okay.
I always get that as a tough one. And of course, I agree with you. Immunotherapy is taking front and center stage. The notion of chemotherapy is a little bit of an antiquated one at this point. For the majority of things we do, we still use chemotherapy. We use it for transplant. We use other new drugs. And in fact, there are newer drugs that use chemotherapy in kind of interesting ways. But I completely agree with you. We're shifting more towards an immunotherapy approach. And really what that means for a patient is classical chemotherapy looked at myeloma as an immune disorder and said, well, the answer is just knock down all immune cells, good and bad. And the kind of brass ring promise of immunotherapy is no. There's certain cells that we want up. We want your immune cells that attack cancer to go up, and we want the cancer cells down. So that's really the direction that we have a lot of these new drugs in and new treatments. So I couldn't agree more.
Well, the drug that we're talking about today is Belantamab Mafodotin, also called BLENREP, and I'll let you explain all about BLENREP.
Sure. So BLENREP. So first off, just kind of getting to the drug in the first place is, chemotherapy or classical chemotherapy, which was invented around World War II, was invented with the notion that cancer cells divide rapidly without following our body's cues of that cancer cells should die. So it just killed things randomly. Now we use targeted agents, or agents that are specifically targeted for something that's on the cancer cells and hopefully or ideally nothing else. So BCMA, or B cell maturation antigen, is an antigen. It's basically a marker. Think about it that all myeloma cells have a little flag of BCMA sticking up on it. Now, there are a few other cells that do have this, a couple of other immune cells like certain B cells, but it's not really heavily expressed in a lot of other tissues, which makes it ideal. The optimal target for a targeted therapy is on all of the cancer cells and nothing else. It is a very easy target. There are 3 different ways that we're currently targeting it. One is with Belantamab, which is an antibody-drug conjugate, which we'll talk about. The 2 other ways are with CAR T cells, which I think a lot of the people listening in are very familiar with, where we collect your T cells, train them all to target BCMA and put them back in your body. And the other method is something called a bifunctional antibody. It's got 2 arms. One targets BCMA and the other targets something called CD3. That's a marker on all of your T cells, your immune cells. So it basically takes the cancer cell, takes your immune cell and activates it and helps it fight the cancer cell. But BCMA is a really great target, and we have a lot of ways of exploiting it. And kind of an interesting new way as a result is this BCMA can actually float off of the cell and just kind of circulates. We call it soluble BCMA. And that's actually starting to be a lot of research into using that to monitor myeloma. It's a really interesting thing because people have soluble BCMA regardless of what type of myeloma they have. The other kind of cool benefit is it has a very short half-life, around 24 hours. And what this means is we could start you on a treatment on a Monday, check your soluble BCMA, and by the end of the week, really have an idea of whether or not this regimen is going to work. So that's kind of looking forward to how we're going to be using BCMA in the future. But for the moment, what we're really using it for with BLENREP is as an antibody-drug conjugate. So really what that is it has a part of an antibody that attaches to that BCMA. And then once it finds that cell, it injects it with a poison. That's really what that means. It's an antibody conjugated to essentially a poison. And there's a number of these drugs that we use throughout different types of cancer. Now, Belantamab, Mafodotin, also called BLENREP, previously called GSK 2857916, is basically an IgG antibody. And some of you may recognize that IgG is the most common type of myeloma because, again, this is an engineered antibody, just like the type of antibodies that your bad plasma cells make. But this one is specifically engineered, and it targets BCMA. And as you can see on the right, once it finds the cell, it kind of gets taken in and dumps that toxin into the cell. And that toxin is something we call MMAF. And MMAF ultimately kind of triggers the cell to die. And there's actually a number of mechanisms of how it kills the cancer cell. It kills through antibody-drug cytotoxicity. It kills through immunogenic cell death. There's a number of different pathways, but the kind of 10,000-foot view is it links onto the cancer cell, injects a poison, and kills it. It was approved by the FDA in August of last year for patients with relapsed and refractory myeloma. That means myeloma that has come back and is not responsive to other therapies. But for patients who've had at least 4 prior lines of therapy, including a proteasome inhibitor like Velcade, an immunomodulatory drug like Revlimid, and an anti-CD38 antibody like daratumumab. So if you got something like RVD, and then you got Darzalex, and then you got pomalidomide, and then you got Kyprolis, then you would be eligible for this type of drug. So the drug, this is the first antibody-drug conjugate that was approved in myeloma. We have a number of these therapies approved in leukemia and lymphoma, and they're extremely efficacious in those settings. This drug is given at about, the starting dose is 2.5 milligrams per kilogram, given as an IV therapy over 30 minutes, once every 3 weeks. One of the really nice things about this is that it's approved without a steroid. So steroids are the great double-edged sword of myeloma. Some people love them, some people hate them. but steroids often take a toll, and this is really nice that it's a drug that is actually approved without any steroids. And for those of you who want to see what this molecule looks like, I found something down below of this gigantic molecule, Belantamab. And the FDA approved this drug based on a study called the DREAM-2 study. And the DREAM-2 study looked at giving Belantamab in patients who had multiple previous lines of treatment, and it evaluated it at two different doses, 2.5 mg per kg and 3.4 mg per kg. And this is just some of the general overview of that trial. Basically, patients were looked at in these two different arms and evaluated for how well they responded and side effects that they had. So these are the two different arms, the two different doses, and you could see that patients had an average of around 6 to 7 prior lines of therapy, but some of the people had over 20 lines of prior therapy. So the drug is not yet approved for the early types of relapses. It's generally for the later on. The overall response rates are around 30%. And at first glance, you may say, well, 30%, that's not all that much. But if you look at essentially all the drugs that have been approved in myeloma, when they get approved at the end of the line, and they have about a 30% response rate. So Darzalex, that has this amazing response early on. When you give it at the end, 30%. Pomalidomide, 30%. Selinexor, 26%. Melflufen, 29%. So essentially, the way all drugs kind of evolve in myeloma is they first get an approval towards the end by themselves, and the response is about 30%. And as we figure out the better ways of giving it, we move it further up and in different combinations, and those response rates improve quite a bit. The median progression-free survival was around 2 to 5 months. And again, that's time that you're in remission, and the overall survival had not yet been reached, which was really, really nice. Now, the big issue with this drug, the main issue, is ocular or eye problems. It causes corneal events, or something we call keratopathy. So corneal events or abnormalities in the eyes occurred in 3/4 of the patients. Now, this could be something very mild, like a little bit of dry eye, a little bit of change in your visual acuity, but can progress to something like blurred vision and decreases in seeing. In general, this was reversible. And it was mainly reversible by holding the drug and allowing the body to heal itself. We've tried a lot of things to help prevent this, like eye drops, different types of eye drops. But for the most part, the way we manage it is by spreading this out from every 3 weeks to something like every 4 to 6 weeks. As a result of this, the FDA approved the drug with something called a REMS, a risk evaluation and mitigation system. And what this means is that your provider has to go through a variety of steps to give this drug to you. And the main one is that every time you get a dose of the drug, within 1 week prior, you need to be evaluated by either an optometrist or an ophthalmologist to make sure that you're not having any untoward side effects with the drug. So things we look out for. The main one is the eye side effects. It tends not to be very heavy on the bone marrow, but it can lower the platelets a little bit. Infusion reactions are quite rare. And in clinical practice, really, the drug is one of the better tolerated drugs globally, with really the two side effects being eye side effects and a little bit of a lowering of the platelets. How do we manage this? Again, platelets we monitor. We only give transfusions if need be. There are growth factors if we need to give them. Really kind of working with your eye doctor to make sure you're not having any significant changes, because many people who start the drug already have some low-grade eye changes or a little bit of a cataract or a little bit of blurry vision that's happened over the years. So we need to put everything into context. We do recommend lubricant eye drops, but really the biggest trick at the end is that if you get these issues, we space out the doses. When your ophthalmologist or optometrist evaluates you, they're really looking for, on their end, things like changes to what's called the corneal epithelium. That's the outer lining of it. Even ulcers. So, I know a lot of people say, well, my myeloma is acting up, I need my dose. We don't want to push the dose too hard because those changes may be more profound. Any issues with dry eyes, their ophthalmologists have a ton of different supportive care options to control that. If there's worsening symptoms, again, we mainly hold the drug. And unfortunately, that may mean weekly visits to the ophthalmologist or optometrist until your symptoms have recurred. improved. Now, again, as we talked about, drugs always start at the end by themselves, and then over time we learn how to use them earlier on in better combinations. So the whole program with BLENREP is called the DREAM program, and there's DREAM 1, 2, 3, 4, 5, 6, and so on. DREAM 6 is the most mature of all the combinations right now. And this was presented by some of our colleagues down at the Winship Cancer Center at Emory recently. And basically, this is combining BLENREP with bortezomib and dexamethasone, drugs that many of you may already be familiar with. And really, a lot of the study initially was trying to sort out what's the optimal dose of the BLENREP, what's the optimal dose of the bortezomib. But as you can see here, when you give a drug earlier on in combination, the response rates change quite a bit. So here in this trial so far, the overall response rate was 78%, with half of the patients having more than a VGPR. That means more than a 90% reduction in their myeloma. So people in this trial are currently doing amazingly well, and it seems to synergize very well. So this may be a combination that is approved in the not too distant future. So instead of waiting for BLENREP to be at the end by itself, we move it a little further up, combine it with Velcade, and get much better responses. In terms of the safety, again, the same two issues that we saw. One of them was the keratopathy, which again here was around 40%. Again, the data is still early, so the numbers can fluctuate quite a bit. And thrombocytopenia or a low platelet count. The majority of this was not very severe, and it's easily manageable, but something for your care team to look out for. So far, about 59 patients have been treated with a combination of Belantamab, Velcade, and dexamethasone. The majority of people seem to be doing well on the 2.5 milligram every 3-week dose of the drug. It seems to be better profile than when it's given at the end. And so far, the overall response rate, again, almost 80%, with about half of the patients having severely large responses, more than 90% reduction in their myeloma. This study is ongoing. One of the other things you'll see here is something called a CBR, a clinical benefit rate of 83%. Clinical benefit rate means you've had a minor response or more, so 25% reduction to 49 or 29 or 25% or more. And the example I give is if you've had all your different therapies and you get onto the study or therapy with an M spike of 1 gram and you get down to 0.6 and you hold it there, they don't count you as a partial response because it's not 50%. But if you went from 1 to 0.6 and held it there, we'd be pretty happy with that. So again, this combination is excellent at controlling disease. What's the next stage? Well, this is a list of all the current trials that we're looking at, DREAM 3 through DREAM 11, and then so on. And as you can see on the right, these are combinations with a lot of the drugs that we know have activity. So combining BLENREP with drugs like pomalidomide. The DREAM 9 study is looking to add BLENREP initially as your first therapy. So a lot of people will get RVD as their first line. DREAM 9 is looking to add BLENREP to the RVD to see if we can make that even better. There's a couple of other studies that use some drugs not quite used very often. So DREAM 4 is combining this with pembrolizumab, which is a checkpoint inhibitor. It's also called Keytruda. You may see advertisements for this drug on television. It's one of the big drugs we use to treat lung cancer. And although initially some of these studies with pembrolizumab in myeloma were not so great, we do feel that there is a major role for this type of therapy. So the combination studies are very interesting. A lot of the other studies are looking to combine with just standard of care. And the benefit of this is that it answers some general questions. You know, if we were going to give you Darapom, what happens if we give you Darapom plus BLENREP? Do we increase the response rate, but do you get too many side effects? Again, one of the benefits of these larger combinations is BLENREP is tolerated better when you give it at farther intervals. So instead of giving it every 3 weeks, every 4 to 6 or even 8-week intervals, people seem to have less toxicity. But you need to give it with other drugs to get that synergy to control the disease. So very interesting where the drug is going to go. And we don't know yet what's going to be the optimal combination, but we're getting there. And that's all I have about BLENREP, but more than happy to take any and all questions about the drug or anything else Jenny tells me to.
Okay, well, I have some questions, and while we're waiting for you all to add your questions in the Q&A, Let's go through some of those. So when a drug gets FDA approved, I know that, you talked about this 30% response rate, but in myeloma care in the real world, you're not outside of clinical trials, you're not necessarily going to use this drug by itself for a highly relapsed patient who's had 4 prior lines of therapy and relapsed, right? So, can you share how in the real world it's been, because it's almost been a year, right?
Mhm.
And you have a little more experience using that. So, how is it being used?
So I think it's used in two ways right now. And I think the way you said it is perfect is, you know, selinexor is the great example. Selinexor was approved kind of by itself at the end and at the end of everything. And then this minute was approved, we weren't just giving selinexor. We
Mhm.
looked to the most mature data. And at the time, that was selinexor and Velcade. And the majority of people that we treated off the bat were with selinexor and Velcade. So we have a number of patients where we're giving Belantamab and Velcade following the DREAM6 data, mostly because it's the most mature. And even though there may be another great combination out there, there's a little bit of a hesitancy because you never know when you combine two drugs. You
Mhm.
know the side effect profile of one and the one or the other, but when you combine it, you may not know it. So we know that it's well tolerated with Velcade. We're giving some of the patients that. We do have a number of patients who've really gone through everything, and we're just giving them BLENREP by itself. We do have a number of people on it, and for some people it doesn't do much, but for some people it gives them these very fast drop-offs of their disease, and they do great. So we're kind of split. Half are just getting the drug, the other half are getting the Velcade.
So, for the people that are responding really well to it and it's very useful for them, is there a profile of person that you're seeing?
So we don't yet know who will respond very well to the drug. But one of the things, we talk about the three different ways we're targeting BCMA: CAR T, bispecific antibody, and ADC, which is BLENREP. And this has actually a particular advantage for people who've had a lot of therapy that doesn't always seem very obvious, because a lot of the hoopla is within CAR T. And CAR T is great, but it could be a bit toxic and it's not going to be appropriate for everyone. So that kind of leaves us with the bispecific antibodies and a drug like this. The more treatments that you have for your myeloma,
Mm-hmm.
your T cells may get kind of tired. And one of the things we worry about is that if you've had myeloma for many years and we give you a bispecific, for some people they work great, but for others, their T cells are kind of exhausted. So when it grabs the cancer cell and grabs your T cell says, I don't really do that much. So the drug doesn't work as well. The
Mm-hmm.
benefit of this drug is that even if your T cells are exhausted, the drug doesn't care. It doesn't use the T cells as much to kill the cancer. It really just finds the cancer and kills it directly. So we have a feeling that bispecifics may be better earlier on in the course of things. And if we're going to use a BCMA based therapy later on, ADCs like this may be better.
Yeah, that's what I was going to ask you is about positioning, because I think selinexor was a good example. At first, they started using it very late in the game, right? And then there were a lot of side effects to it. So now they're reducing dose and they're learning how to use it very effectively with minimal side effects. And what you said about the 4 to 6 week dosing as well is the same. So as you gain experience with some of these drugs, I think it's important for patients to know that there are things that you, as a physician and a myeloma expert, can do to administer these types of drugs without and be very nuanced about it. Okay, well, let's space it out a little bit more, or and that's why I think when they did the trials and the 2 doses were selected, there were fewer side effects in the lower dose, but almost the same efficacy.
Mhm.
So you're getting a drug that works just as well at a lower dose to minimize the side effects. So anyway, do you have any comments on that?
No, it's just we only learn so much because we're all anxious to get more drugs out there and into the hands of patients. We do a lot of our learning after a drug gets approved. Some of the people listening may not realize that Velcade used to be a totally intravenous drug. and it used to cause neuropathy in large numbers of people. Then we learned well after it was approved, years after, that giving it subcutaneously, far better tolerated, same efficacy. Selinexor, when it was first approved, we gave it twice a week, very toxic twice a week. Now we give it once a week in combination, far better tolerated. Same thing with BLENREP. It's got the approval, but as we get it in the clinic, exactly as you talked about, we gain experience. We all, as a community, see how to nuance it better or worse. So I think the future of this drug is going to be in combinations and probably given every 4, 6, or even 8 weeks. If you give it early on with something like RVD, that backbone is so good, you could probably get away with giving it every 2 weeks, have far less eye problems, but actually really increase your responses.
Okay, that's so fascinating. And I hadn't ever heard of that before with the antibody drug conjugate versus the bispecifics. I was only familiar. So you're essentially using the immune system to deliver, like to track and train, and then it delivers that payload. So it's a totally different mechanism of action, I guess you would say, as the bispecific. So totally different way of working. Um, I was wondering if corneal issues are kind of normal for antibody drug conjugates, because I know there's another one in development in the myeloma space, and they also were having some kind of eye toxicity
Yeah,
issues.
Medi-224. It's an
And,
AstraZeneca drug.
yeah.
Yes.
And you want to explain why the eye is involved?
Not very well, because it's kind of known, but it's not exactly fully known. It has to do with the payload itself. The other antibody drug conjugate uses a slightly different payload. The original thought was that there's some inflammation in the eye as part of this payload, and the answer is just to give steroid eye drops to reduce that inflammation. That didn't really pan out. Some of this is probably just direct toxicity, that some of the poisons that we give have a tropism where they just happen to go to certain areas. For example, there was another antibody drug conjugate for leukemia called gemtuzumab ozogamicin. And the poison it gave was something called calicheamicin. And it just so happens that it would inject it into the leukemia cell and kill it, but that calicheamicin happened to go for the liver. So then people would get liver abnormalities. It just happens to be that the poisons that we're targeting with these drugs, for some reason, go to the eye.
Okay. Diane has a question. She's saying, I had one treatment of BLENREP, that she had bad keratopathy, so the treatment was stopped. The next treatment would be CAR T cells. Isn't that the same class of drugs, which you kind of mentioned that it's not, but you can elaborate. And then would you advise going on to something else? And I would suggest a follow-up question, like something else that's BCMA targeted.
So several facets to this. One, it targets the same thing, but it's not the same class. So we would call BLENREP an antibody drug conjugate, and Abecma is a CAR T cell. Yes, they both use the same target, but that doesn't mean they're exactly the same. You can get a CAR T after BLENREP. We call this sequencing, getting one targeted therapy after another. So we're asking the same question with drugs like daratumumab and isatuximab. What happens when you sequentially use them? We don't know all that information yet. Same is true with BCMA therapies. We're starting to have patients who get a bispecific that targets BCMA and then a CAR T, or the other way around, or BLENREP and a CAR T. We simply don't know the answer yet. But again, even if BLENREP is having toxicity, it may be that methodology works very well for your myeloma. And the benefit of a CAR T is exploiting what your myeloma is sensitive to without the eye problem. So again, without knowing the specifics of your case, it probably is a very good thing to go after a CAR T.
Mm-hmm. And then sometimes I don't know, like, I, the question, I guess, is when you introduce a new drug like this into the clinic, myeloma specialists, because of the number of cases that they are treating, are going to see and gain that experience faster than, let's say, a general oncologist who's treating, 15 different cancers and seeing maybe 5 cases per year that may or may not include BLENREP. So how do you, like, if you have a general oncologist who's prescribing, and there is keratopathy and they don't know really what to do with it, are they more likely to just kind of stop and say, let's try something else? Or like, and what do you suggest to those types of doctors when they call you for advice?
Absolutely. So we do know this, that the general hematologist oncologist that does know way more about every other cancer is more likely to stop a drug because of toxicity, because they don't know all the tips and tricks of how to kind of navigate that. I think it really depends upon where they're at. Do you have anything else that's after BLENREP? Unfortunately, right now, most people who get BLENREP tend to get it towards the end of standard options. That
Mm-hmm.
doesn't mean that there aren't other options,
Mm-hmm.
but my philosophy is until we have 100% cure for 100% of people, you stretch out every response from every drug in whatever way you can do that.
Mm-hmm.
Again, I think what this brings up is something that we've known, is that for people at any point in their time, any point in their journey with myeloma, it's important to have at least one consultation with a myeloma center. And it doesn't have to be mine, it could be any of them. Even, listen, in the world of COVID, you can do telemedicine visits. I literally saw patients yesterday from all over the country, and a few patients from in other countries, a patient we saw from South Africa and someone we saw from England. You can do this to get that depth, and we can have conversations with your physician to help negotiate that. So I think your audience is far more educated than the average, so they're probably already doing that. But if not, at least one conversation with a myeloma clinic will definitely help.
No, definitely. I mean, take advantage of it, right? I mean, we have it, and yeah, I think we should never have had any kind of cross state line restrictions because we're going to fly to you anyway and go see you, in person. So to me, it doesn't make any sense that we had that in the first place. But with COVID, it's been really great. So yes, you should get a second opinion from a myeloma specialist, especially when you're making treatment decisions to start or stop certain things. I think that's just a critical and when you're newly diagnosed, critical times. Okay, Paul is asking a really good question. My wife is on Belantamab for 7.5 months. She's been cancer free for about 6 months. She's taking it every 6 weeks. So how long do you expect the drug to continue to work? I know you can't talk about personal experiences, but interesting, using it as a single agent drug. It's being very effective. They're doing it almost as like a maintenance therapy, it seems like.
Yeah, one of the things, the problem with looking at the average numbers in these trials is that it lumps people who had no response in with people who had amazing responses, and it kind of jumbles up all the data. I have to be honest, the people that I've seen respond to it are doing amazingly well for very, very long periods of time.
Mhm.
One of the things we see with a lot of medicines is that the numbers go down and then they come back up. But there's something about BLENREP that, either it seems to not work at all, or you just go down and stay in control for some very extended periods of time. And right now, being able to maintain that is amazing, because we're going to see several new therapies emerge, FDA approved, within the next year. So, a lot more to come.
Mm-hmm. Yeah, well, that's interesting that the responses are so long. And even when they're dropping the dose or spacing the dose out a little bit longer, for those patients that are responding to it really well, are you seeing that maintain?
Yeah, and that's something, again, that's kind of unique about BLENREP, is that, if we had people on Kyprolis doing well, and then we decided, they're having side effects, let's give it every 6 weeks, wouldn't get the job done. But
Mm-hmm.
a lot of these antibody drugs have long half-lives, and they're able to maintain it. So we have a number of people exactly like this person, who,
Mm-hmm.
we could space it out every month and a half, and even some people get it every 2 months.
Mm-hmm. Okay. Another question from Dawn. What are your thoughts on using BLENREP after CAR T, with the possibility of BCMA not being expressed after CAR T, and can that be tested for? And I've heard some of the experts say, like, it's not necessarily the loss of BCMA that's causing a relapse after CAR T. So maybe you really want to elaborate on that.
Sure. So, complicated question. Number one is, you're absolutely right. It's not always loss of BCMA. In fact, one of the mechanisms of resistance happens to be what we call checkpoint inhibition. So, combining drugs like pembrolizumab that we talked about in that setting may be really helpful, but very complicated. you can actually test for BCMA expression. And centers like ours are doing that because we do know that some of the mechanism is loss of BCMA or could be. And I think a lot of this about using BLENREP after CAR T has to do with timing. I think if you progress after a CAR T within a short period of time, like 3 to 6 months,
Mhm.
odds are BLENREP's not going to get the job done there. However, if you've been in remission for a long time after a CAR T and then the disease comes back, then BLENREP will probably have a better chance of working from a lot of standpoints, both in terms of BCMA being there, but the rest of your immune system kind of leveling back up.
Mhm. Okay. Elaine, well, Chrissy is asking, and by the way, she is the first Bluebird CAR T patient from Hackensack.
I know Chrissy. I used to work at Hackensack. She's harassed me plenty. She's the best. Love her.
She is awesome. Chrissy, we love you. Okay, she had one BLENREP infusion early March. About 18 days later, her vision changed. She's giving it another 2 weeks to resolve before doing the next. She's had every treatment, so BLENREP is one of her few options. Is there any way to speed the eye issues along, or how does that work?
So, um, first of all, there's often other therapies out there. So again, I haven't seen Chrissy in a long time, and I wish her nothing but the best. But there's always a lot of other things down the road. I wish there was a way to really speed it up. I think, we have our patients see the ophthalmologist to kind of figure out any little eye drop that might help. But for the most part, it's really tincture of time. So I don't know if there's any good way to speed it up.
Mm-hmm. Okay. Okay, I have some other questions, and then we'll go to Elaine's questions. So when you talk about, I know that you talked about the eye issues resolving. Can you explain exactly how they resolve and why they resolve? And then I know I've heard a lot of patients ask the question, but if I go back on, then do I have the same eye issues? Do they ever get any different? Or what can I expect if I take a breather in treatment?
So, exactly the kind of granular level of how it gets resolved. I think much of that has to do with the clearance of the toxin not actively affecting the eye. Unfortunately, it is possible that you develop eye problems, you hold the drug, it gets better, you redose, and it gets worse again. It's not always the case because, again, it may have been that initially you got it every 3 weeks. And then if you're come back down to your baseline and space it out, it just may not be enough toxin to affect the eye to cause those problems again. Outside of that, I think we're still all rushing and struggling to better understand the eye problems and how to get them better faster.
Mm-hmm. And I guess I want to hear from your experience because I've heard some patients say, "Oh, I don't want to try that drug because, I might go blind or something." But it's not like that. So can you explain what you've seen?
Sure. I have to be honest, a lot of my experience with the drug, I've had patients that clearly notice changes in their vision, but I've also had a lot of patients who actually notice no change, but their ophthalmologist notes some change in their eye exam, and they say, "Well, I feel fine. Just give me the drug." And so it's not that you take one dose of the drug and you go blind. It generally happens that the vision just gets a little blurry. But again, we've had a lot of patients that only have a little bit of a worsening. They notice nothing at all. But we hold therapy because we know that if we push it at the wrong time, the toxicity could get much worse.
Mm-hmm. Yeah, and it's an abundance of caution always for myeloma drugs, right? So if anyone can have a side effect, that's why they have the REMS program and all of that. And you do go to your ophthalmologist beforehand and during and and all sorts of times so they can check on that, right?
Absolutely.
Okay, so Elaine is asking, her immunologist says she has no T cells. Is BLENREP still an option for her?
Absolutely. And in fact, for someone without T cells, a therapy like a CAR T may not work because they may not be able to collect enough T cells to to manufacture and give you back. A bispecific antibody may not get the job done. So because BLENREP is not as dependent upon them, BLENREP is a really good drug for someone in that scenario. Now, it's interesting because we're seeing this with some patients that when they have lots of different treatments, they may not have as many T cells. And one of the things that we do sometimes for patients is kind of an immune reset. And the way you do that is a lot of people are very familiar with autologous transplants, where we give you big doses of melphalan to kill your stem cells. We give you back some healthy stem cells and we replenish them. Sometimes what we do is prior to going forward with some of these immune therapies, when we know their immune systems are beat up, we can give you almost a mini transplant where we don't give you the same intensive chemo, less so, but we give you back some fresh, healthy stem cells to make not only new healthy stem cells, but new T cells, which may give you a better response to other therapies later on. Again, this is a bit of a moving target and we're learning as we go here, but we've done these immune resets for some patients to make them not only eligible for more trials down the road, but to maybe make those trials work even better.
Mm-hmm. It's fascinating how many trials they have open. And I want to encourage everybody to add more questions. So, because I don't want to monopolize the entire time. Okay, so Chrissy's also asking, did you say that if you have CAR T, you could lose the BCMA, and we have to have the BCMA for BLENREP to work?
Very few things are all or none. You may have downregulation of BCMA. You do need at least some BCMA usually for BLENREP to work. But what we typically find with a lot of these drugs is that you don't need to have a ton of it to get the job done. So for example, the amount of BCMA you have didn't seem to affect whether or not CAR Ts work or not in
Right.
general. So initially we thought only people who huge expression of BCMA is going to work. And if you have low expression, it's not going to work. But it turns out, even if you have a little bit, CAR Ts will work. We saw this with another antibody drug conjugate called brentuximab vedotin, where it targets something called CD30 in lymphomas. And we used to think you need tons of this for work. And even if you have a little bit, it gets the job done. So, I think for someone who's had a CAR T and been in remission for a long time, obviously you could measure the BCMA to get an idea. But much like coronavirus, when you measure the antibodies, we don't exactly know what that level means. So yes, we have an idea of high, middle, or low, but you could have high BCMA and it not work. You could have low BCMA and it does work. So there's a lot more involved than the raw amount of it.
And doesn't BCMA kind of regrow also if you stop therapy for a time? So
It does. It can be re-expressed again later on down the road, which again is why I think that, if you progress after a CAR T after 3 months, probably not the right time. But for those who've been in remission longer, I think it's a better option.
Okay. Okay, and Denise is asking, she's doing the Poseidon CAR T trial. It had failed auto stem cell transplant in 2013 and was not able to engineer T cells for the first Poseidon trial, sounds like, and just started second apheresis for a separate CAR T trial. So if the trial's unsuccessful, or the same trial, I guess, if the trial's unsuccessful the second time, is BLENREP something that she could consider?
Sure. I mean, again, the devil's in the details. What other options are available? And why is the engineering failing? Is it failing because there are not enough T cells? Is it failing because the T cells are not strong enough? And again, these granular problems may provide ways of fixing this. So when someone says they fail an auto transplant, is that they have a transplant and were in remission for a very long time. If you have cells left over, this may be a scenario where doing that kind of immune reboot may allow sometime down the road an easier ability to pherese and engineer T cells. But BLENREP is definitely an option for people for whom CAR Ts may not be available. But again, for an individual, I'd say really talk to your care team about all of the available options.
Okay, Ernie and Cindy are asking a question about allotransplant. Now, allotransplant is not necessarily used very frequently in myeloma care, and it's always like this risk-benefit, trade-off, and it's mostly autologous transplant. But they're asking, with your immune reset with a mini transplant, is that an allotransplant as a source of healthy T cells, or an auto transplant?
No, it's just an auto transplant. So with an allo transplant, you can get more donor T cells to help fight the cancer. But really, with this kind of immune reset, it's your own cells and a little bit higher up. It's basically taking stem cells that were collected before the onslaught of years of treatment, giving your clearing out space in your marrow by giving chemo, giving you back those older stem cells that were frozen at the time when they were not as perturbed by chemo, and then allowing them to not only grow in your marrow, but make new healthy T cells that are all your own. Allo transplants, you can do allos before or after CAR T. It does make it a little bit more risky for some people because of risk of graft versus host disease. But this type of immune thing is really with your own cells.
Mm-hmm. Okay. Let's talk for a minute about just keratopathy in general and what that word means, because I think sometimes when patients hear keratopathy, they don't really understand what it means. I know that it can be observed, like you were saying earlier, it can be observed by an optometrist or an ophthalmologist, but maybe when it's called keratopathy, patients don't really register because they're not having any side effects.
Sure.
So maybe you want to explain that because it's kind of a new term for myeloma patients, right?
Absolutely.
Mm-hmm.
Man, I should have brushed up. It's not my specialty. But basically, we add the word opathy basically anytime there's a problem. So neuropathy is a problem with the nerves. Dermatopathy is a problem with your skin. Keratopathy is basically problems with the cornea where it just kind of gets a little cloudy, and light doesn't get in as well, and it can diffract and basically just makes the vision a little blurrier. And keratopathy is just kind of an overarching term that we use to describe a number of things. So much like when we talk about neuropathy, which a lot of people with myeloma may be familiar with, neuropathy could be numbness, it could be tingling, could be pins and needles, it could be pain. All of those fall under the umbrella of nerve problems. Same thing with keratopathy. You can have ulcers, you can have clouding of the cornea, you can have some deposition there, but it all falls under the rubric of abnormalities with the cornea or with that top epithelial layer just getting a little cloudy.
And the eye tissue is constantly regenerating. I heard someone say it was regenerating like every 30 days or something like that, which is why some of the side effects don't last a long period of time, right?
Absolutely. So, I mean, that's for the most part why the biggest fix we have right now is tincture of time. It's not so much that we can fix those epithelial cells, it's just time for that to regenerate, the bad cells to kind of slough off, and the new ones to come in.
Mm-hmm. And I think it's so fascinating because let's talk about it in the newly diagnosed setting, because you talked about that study that was being used in newly diagnosed. Was it RVD that they're adding it to? I can't remember.
Yeah, the DREAM9 study is looking at Belantamab plus RVD.
Yeah, so there have been very few BCMA targeted therapies being, well, maybe in clinical trials, but there aren't any that maybe I just don't know of any that are being used right now, like in quad therapies. You're seeing daratumumab and isatuximab and things like that used in the newly diagnosed setting, but not really these BCMA targeted therapies yet. Is there any indication of, well, I just guess you have to get the data from the from the trials, but it's an interesting idea to use. There's so many different combinations that you can use at this point now. So I think that's a fascinating study design.
Yeah, I mean, one of the big questions that we're always asking is where is a drug going to give us our biggest bang?
Mm-hmm.
And the big hot topic right now is actually daratumumab. Is it better to give daratumumab upfront as part of the initial treatment, or
Mm-hmm.
best to save it for the first relapse or the first time the disease comes back? And we don't know yet. We're trying to figure this out with modeling and looking at large data sets, but we just don't know. We do know that the earlier you use therapies, the better they work.
Mm-hmm.
We know that the majority of people in the United States only get around 3 to 4 lines of therapy. So we want to take advantage of making sure for those first few relapses, we use our best drugs to really get that deep remission. In terms of the quads, unclear how well the quads are going to factor in because RVD has a response rate of almost 100%.
Mm-hmm.
The benefit of adding a fourth drug, it's not that more people respond, it's that on average the responses are deeper. And again, the benefit of adding belantamab early on is that, uh, towards the further along the line of relapse, giving belantamab every 2 months, it may not be enough to control the disease. Whereas early on, because you have that big backbone of RVD and your disease is so sensitive, we can add a dose of it every 2 months, no big deal.
Mm-hmm.
Problem rates are going to likely be much reduced. So, ultimately, I don't think that belantamab is likely to be there, simply because daratumumab has really had a big impact in the initial phase of treatment. And the problem with using belantamab as your first line is, well, again, we're still trying to figure out sequencing. So if things like CAR Ts or bispecifics are going to be big time drugs in the first or second relapse, you may not want to
Mm-hmm.
use a BCMA drug first if you know you're going to use it second or third.
And then you talk about T cell exhaustion, and that's kind of some of it. Like, should you be using these CAR T therapies or bispecific antibodies up front when your T cells, hypothetical? Well, you have myeloma, so I don't know how healthy they are in the first place, but you haven't had multiple lines of therapy either. So that will be interesting to learn. Okay, we have other questions. Kathy is saying, thank you for doing this program. I was not responding to many drugs as my myeloma has morphed to extramedullary myeloma and tried BLENREP. After 2 treatments, tumors were shrinking, and now have had 6 treatments, and she gets it every 6 weeks and a lower dose. Second PET scan showing amazing results. Do you think it could be a time where they're tumor free, never had a stem cell transplant, or stick to the drug? Should she consider a stem cell transplant, or just keep doing this? Have you had patients who have used this time to then go to transplant or CAR T?
Yes.
That's
So in terms of transplant, a lot of this will depend upon what duration of therapy you had for the first one. Because a few general things, in general, the deeper remission you are going into your transplant, the longer you stay in remission. And if you had an original transplant and you do the same type of transplant again down the road, the average response rate is around 40 to 50% the duration of time. So I think this person said they had a transplant in 2001. If they relapsed in 2002 and have been on different treatments since then, I don't know that I would go to a transplant right now. But if
Mm-hmm.
they're the type of person that had a 3, 4, 5, 6, 7, 8, 9, 10-year remission from their first transplant, and you have cells frozen, this may be a great time to do that, because, by the time the disease comes back, we'll have who knows what available by the FDA. So absolutely.
Yeah, that's amazing. Okay, I have, I think, 2 more questions. So I just wanted to highlight that you talked about that you thought steroid drops might be effective to reduce the eye issues with the keratopathy, but that did not have any impact. So I just want patients who are taking BLENREP or considering taking BLENREP not to think, well, I can just use steroid, eye drops and have that be better. So I just kind of want you to highlight what you said again, because I know you already said it, but
No, of course. I mean, for the most part, the majority of drops that we give are lubricating eye drops, basic, not much fancier than like the Visine you'll get over the counter. However, the benefit of seeing an ophthalmologist is if there are other eye issues, and we all have probably some at some level, they may provide other drops to maximize absolutely everything else, so that the impact of the BLENREP on the eye is such a small thing globally that you can go on to your next dose. So this is not the type of thing where if you have blurriness to take a bottle of steroid eye drops out of your partner's or friend's medicine cabinet and start experimenting, because they can cause other problems.
yeah, right. Okay, the last question I want to ask is a really important one. So, is it helpful to combine BLENREP? We talked a little bit about what to combine BLENREP with, but when you've relapsed and you've kind of gone through, well, 4 lines of therapy is a lot of therapy, right? Because typically you've gone through most of the major courses of myeloma drugs. But can you go back? Have you seen anything? And I've seen this sometimes, or heard this sometimes from other myeloma experts, that like they'll try a drug and it'll kind of they relapsed to Revlimid, and then it activated again. And actually, I was working even with Revlimid in the combination. So, are there things that you can try it with that you have become relapsed or refractory to? I guess.
So there are certain drugs that we know both in vitro, meaning in the lab, and in clinical practice can resensitize you to drugs that used to work and now don't. The two biggest examples of this are actually selinexor, and the biggest one is panobinostat or Faradak, which is not a very widely used drug. But we do have evidence that if you are refractory to a drug like Revlimid or Velcade, and we add a drug like panobinostat, we can resensitize you to it. I'm not familiar with any data like that so far with BLENREP. I'm not saying that it's not possible, but I have not seen any data yet to show that it can resensitize you to that. That's one of those things we're going to end up learning in the clinic over the next months to years. But that notion is definitely there. And at least the way I think about it is, it's not sometimes that a drug is all or none. It's that you make a certain amount of myeloma, you kill a certain amount. And when a drug stops working, sometimes it's just off a little bit. And if you can resensitize it, you can just get it in the right dynamic to where you start bringing the disease down again.
Mm-hmm. So in your practice, if somebody is relapsed on RVD or Palm Daradex or something like that, do you never use those again? If you're going to use BLENREP, you just go to the BLENREP separately, or what do you do?
So one of the things that's kind of interesting is the majority of people are given Velcade up front, but are not treated with it until they're refractory or they have side effects. So if you think about all the myeloma in the US and you combine people into transplant or no transplant, most people who get transplant get RVD, respond very well, a transplant, and then go on Rev maintenance. And people who don't get a transplant typically get RVD and then switch to Rev maintenance. But once people start relapsing, we use drugs like daratumumab and pomalidomide and Kyprolis, but it's very common that people are down to their fourth, fifth, sixth line of treatment and have seen all these different drugs, but are still sensitive to that original Velcade, which is why a lot of times when we bring in drugs like selinexor or BLENREP or Faradak, I combine it with Velcade because they still never progressed on it initially. So I think that's how we're repurposing it. Even though you've had it, you're only really resistant to the Rev and the Palm and the Dara and the Carb, but still not resistant to that Velcade.
Mm-hmm. Okay. There's so much we have to learn. So thank you. I'm shocked that we're almost out of time. Because I this is so nuanced for myeloma patients. And as they come to that fourth line of therapy, now we have selinexor, now we have melflufen, and now we have BLENREP. Like, how do you decide for your patients? I guess that will be my final question for our session today. And then we'll just have to keep talking about these things.
Sure. I mean, when we pick any therapy, our approach is there's three groups of issues: patient-related factors, treatment-related factors, disease-related factors. So patient-related, are you older or younger? Do you have other comorbidities like high blood pressure, diabetes, neuropathy? Disease-related factors is, do you have extramedullary disease? Do you have fast-growing disease, slow-growing disease? And treatment-related factors, did you respond well to drugs like Revlimid? Did you have a lot of side effects with drugs like Kyprolis? And that's how we kind of morph it all together. The question you're asking is on everyone's mind. If you have drugs like selinexor, BLENREP, and melflufen, all approved in the same kind of area, how do you choose? Well, for the most part, we look at side effect profile and administration. So right now, selinexor, melflufen, and BLENREP. Melflufen, for the most part, only has blood count issues. It drops your blood counts and it comes back up. So if you have a lot of other problems, but your blood counts are okay, that's a good drug. But you still need a central line to get that drug right now. Hopefully by the end of the year, the PORT study will be presented to the FDA and we'll be able to give it peripherally. BLENREP I choose for people who have bad blood counts and a lot of other problems, because outside of the eye issues, it doesn't really have a whole lot else. Selinexor, in my mind, is probably the most efficacious of the three at some level, or is at least more combinable at the moment, which makes it higher response rate. So BLENREP, we really only give by itself with Velcade. Melflufen is only approved by itself, and the most mature data is either with Dara or Velcade. But from a study called STOMP, we've seen selinexor with Kyprolis and with Dara and with POM. So selinexor is a little more combinable at the moment. So because we can combine it in more ways, I find it a little more utilitarian for the later lines. But again, selinexor has its own issues. So, but the biggest thing that we choose between the three is side effect profile.
And then I looked just briefly at the, when you were going through the slides with the different treatment combinations. It's in a lot of these studies, right? And being combined with different things. How effective do you think the combination of these two, the immunotherapies, like a CD38, like a daratumumab or isatuximab, with something like BLENREP? I know the checkpoint inhibitor trial is running with pembrolizumab and things like that. That's totally a different class of drugs. But the ones that we're familiar with already, sorry, I can't help myself.
No. So although it's not the same thing, there's a series of studies called the TRIM studies. And the TRIM studies are being run by Janssen, and they're combining a BCMA bispecific antibody with daratumumab. And those studies are ongoing, and they're being done at our institution, being led by Dr. Ajay Chari.
Okay.
And it's not the same, but it's a BCMA drug and a CD38.
Yeah.
And I got to tell you, these combinations in people who've had a lot of therapies, we're seeing unbelievable responses.
Wow.
I mean, to me, the question you're asking about that combo, BCMA, CD38, at least in the clinic so far, big time responses.
Wow. Okay. Well, what's happening is so exciting. We're so grateful that you joined us today to talk about BLENREP. We appreciate you and all that you're doing for the myeloma crowd. And sorry, I can't help the science geek in me ask some of those follow-up questions.
No. I would throw it back, and I would thank you for everything you, HealthTree Myeloma Crowd, do for all of the patients. I see on Facebook all the time how much people love what you provide. So thank you right back.
Well, thank you. And we'll call on you again, I'm sure.
Yeah, that was a great presentation. I loved how clearly you explained things too, because I feel like, even if you have been in the myeloma realm a long time, it still helps to hear things in a simple way. And Jenny, I do appreciate your scientific questions as well, because they help me learn. We're just going to finish the event with a couple of outro announcements. Again, thank you, Dr. Richter, for your time. It's very appreciated. And thank you, Jenny, for helping moderate this event. Our next immunotherapy treatment chapter meeting will be in June. We're not sure about the date yet because we're still securing a speaker, but we are going to do another series in the Know Your Myeloma treatment. And this time we're going to be talking about bispecific antibodies, which we touched on a lot today. It's really exciting. Like Jenny and Dr. Richter were saying, immunotherapy is something that we're focusing on throughout the year. Upcoming events. On Tuesday, May 18th at noon Eastern is our relapsed refractory myeloma patients chapter. And we're going to have Dr. Nina Shaw from UCSF, talking to us about the practical approach to CAR T therapy. Who is it for? What is the procedure like? Who qualifies for it? How can you get a CAR T therapy treatment? Then that same day at 5 p.m. Eastern is the other end of the myeloma journey. We're going to have the launch of our MGUS Smoldering Myeloma Patients chapter. We have Dr. Irene Gobrio from the Dana-Farber Cancer Institute coming to talk to us about the PEAT crowd study, as well as the PROMISE study, which are two game changers, I truly believe, for those with precursor myeloma. Wednesday, May 19th at 3 p.m. Eastern is the Connect with the Myeloma Crowd chapter. We're going to be talking about tracking your key myeloma labs on HealthTree Cure Hub. The whole reason why we have the Myeloma Crowd HealthTree is because we want to make your journey easier for you. We want to simplify the process and educate you and empower you. And one of the ways that we do that is through HealthTree Cure Hub. We provide a way for you to keep all of your records, all of your labs in one place so that you can more efficiently talk to your doctor and your treating team about what's going on and what are the next steps for you to take. So don't miss that event. Thursday, May 20th at 1 p.m. is our newly diagnosed myeloma patients chapter, and we're going to have a frequently asked questions panel with some medical professionals and veteran myeloma coaches. We're going to be talking about that, how to be empowered, how to talk to your medical team, how to ask the right questions. The link to sign up for any of those events that I mentioned and even more events that I have not mentioned today is found at the bottom of the slide and will be included in your follow-up email 24 to 48 hours after this event has concluded. Another thank you to our sponsors, Bristol Myers Squibb, Amgen Oncology, Karyopharm Therapeutics, AbbVie, Adaptive Biotechnologies, Genentech Oncopeptides, Takeda Oncology, and thank you to each of you for spending time with us today, helping us build a stronger myeloma crowd community. We hope you have a great rest of your day. So thank you so much.